Aloha! I'm Dr. Rita Bell Fernandez from the University of Hawaii. Thank you for taking the time to improve dementia capability in our state. Community health workers play a vital role. CHWs can assist with screening clients, educating caregivers, and connecting families to community resources. Let's begin with part 1. Understanding dementia and how to perform cognitive screening. How common is dementia? More than 5 million Americans are living with Alzheimer's disease. This number is only increasing and is projected to reach 13.8 million by the year 2050. What about Hawaii? We have an estimated 29,000 persons with Alzheimer's disease. Do you feel this number is accurate? Actually, a great majority of persons go undiagnosed. The numbers reported are only the tip of the iceberg. Sadly, many people with memory loss do not report it to anyone due to fear, stigma, lack of knowledge. Families might think this is normal aging. Grandpa is just getting old. The consequence of all this results in the diagnosis being delayed for 6+ years after the onset of symptoms. Remember, persons with dementia are 3 times more likely to be hospitalized. They have complex care needs. So what is normal aging? My parents ask me this all the time. As a person grows older, they are still able to perform their activities of daily living and can live independently. Memory remains intact for recent events. There are some changes that occur in the brain as we get older. This slide tells you what changes the most and what changes the least. For example, reading is the least affected, which is why we see so many elderly persons reading the Bible, newspaper, midweek, and magazines. What changes the most is visuospatial skills. Visuospatial skills are needed for movement, depth, and distance perception, and spatial navigation. Remember, dementia is not a part of normal aging. Not everyone who grows old will develop dementia. For persons over the age of 65, 1 in 9 have Alzheimer's disease. For persons over the age of 85, it is 1 in 3. There are many causes of dementia. A person might have dementia from a stroke, Parkinson's disease, advanced HIV, head injury, severe alcoholism, and so on. However, the commonest cause of dementia is Alzheimer's disease. Alzheimer's disease comprises of 60 to 80% of dementia cases. The second most common cause of dementia is Lewy body dementia. There are many risk factors for dementia. The most common risk factor is advanced age. Down syndrome, family history, traumatic brain injury are some of the other risk factors. Let's take a look at this brief video to better understand Alzheimer's disease.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination, and in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
Here is what the brain looks like on autopsy. An Alzheimer's brain is shrunken in size. There are many stages of Alzheimer's disease. The video explains this well. In the early stage, there is mild forgetfulness, repeating the same questions over and over. In the middle stage, we begin to see personality changes. And in the late stage, the person becomes mostly bedbound. So how do we diagnose dementia? Unfortunately, like diabetes, there is no single test to diagnose dementia. During the office visit, the provider will perform a physical exam and cognitive testing. A provider will also order a battery of tests to rule out other treatable causes of memory loss. For example, a low thyroid or B12 deficiency could cause forgetfulness. Ultimately, Alzheimer's disease is a rule-out disease where all tests come back normal. What do we see in the CT scans? Let's look at these 2 brains. In the brain on the left-hand side, we see a healthy senior's brain. On the right-hand side, we see shrinkage, which the radiologists call cerebral atrophy. The red, green, and blue areas of the brain in the lower left corner of the slide is called hippocampus, which is concerned with memory. These areas are much smaller in size in the Alzheimer's brain. Part of the differential diagnosis for any persons with dementia is depression, which could present as a pseudo-dementia, and delirium. These are known as the 3 Ds. Dementia, which is very gradual, delirium, which is sudden in onset, and depression, which develops over weeks. How is dementia treated? Presently, the drugs available have limited efficacy in improving memory. They have been shown to modulate behaviors and delay nursing home placement. Commonly used medications are Aricept and Namenda. Here is where the CHWs play a vital role. Often, the busy provider has no time to perform cognitive screening. As a result, dementia could be missed for several years. Remember, when you perform cognitive screening, please make sure the client is wearing their glasses and hearing aids. Speak slowly and clearly. Do not use the word test, as it might make the client anxious. Instead, I would like you to say, "We're going to do something next that requires some concentration." Do not allow the client to skip questions. They can always guess. Unfortunately, there is no room for creativity. Please do not deviate from the standardized instructions. Do not offer hints or multiple choices. Do not be soft on scoring. There is no half point here and there. Be strict with scoring. Remember, CHWs are screening the person for dementia, not diagnosing. There are many reasons a client could do poorly. For example, lack of sleep, medication side effects, illness, COVID, etc. There are 2 types of screening tools that I would like to share with you today: the AD8 and MiniCOG. The AD8 is a more subjective tool, while the MiniCOG is a more objective tool directly measuring brain function. So which one should you administer? AD8 has the advantage of being able to be administered telephonically. It could be administered to the client or the caregiver. If you are face-to-face, one could administer the MiniCOG with the client or the AD8 with the informant. I would like to begin discussing the AD8. Please look at the handout of the AD8 scale. It would be helpful if you could print this and follow along. Remember, you can administer to the informant or the client. There are 2 ways to administer. You could read the questions out aloud or give them the form to fill out themselves. Kindly use a clipboard. If reading aloud, you will say, "Please answer the next questions with a yes or no." Yes means there has been a change in the last several years due to problems with thinking or memory. No means no change has occurred. In the last several years, has Mary experienced problems with judgment? In the last several years, has Mary experienced less interest in her hobbies or activities? Please read the questions word for word. If the person changes their answer, record their final response. Sometimes life is not so easy and you might get answers like maybe. If caregivers say they are unsure or can't decide, give them a little more time and then say, would you say generally yes or generally no? If a change has occurred because of physical problems or limitations, clarify whether any change has occurred due to memory or thinking. Do not record answers related to physical limitations such as a hip fracture. If the caregiver says they do not know or it doesn't apply to the person, then please check the box NA. To score the AD8, we give 1 point for every yes response. Total possible points is 8. Normal or pass is 0 to 1 points. 2 or more points is considered failed. Please refer this client to their healthcare provider or PCP for further workup. Moving on to the MiniCOG, this is a widely accepted cognitive screening tool all across the United States. The MiniCOG comprises of the word recall and clock drawing. It is quick and easy to administer. It measures multiple cognitive skills such as memory, spatial, and abstract reasoning. To administer the MiniCOG, please select a word list. Versions 1 to 6 are equivalent. Words can be translated into another language as long as the meaning remains the same. Make sure you have the client's full attention. Speak clearly and in a reasonable volume. You will tell the client, please listen carefully. I am going to say 3 words that I want you to repeat back to me now and try to remember. The words are banana, sunrise, chair. When saying the 3 words, do so about 1 second apart. You may repeat the list twice if necessary. If the client cannot repeat them back after 3 attempts, please move on. After the client repeats all the words, do not remind them again to remember the words. For the clock drawing, you will need to turn the page over and tell the client, next, I want you to draw a clock for me. First, put in all the numbers where they go. Now set the hands to 10 past 11. Do not say 11:10. Do not make up your own time. Remember, there is no room for creativity. You may repeat this instruction as often as needed. If the client cannot complete the clock drawing in 3 minutes, please move on. Following the clock drawing, we need to administer the word recall. You will ask the client, what were the 3 words I asked you to remember? Please record their answers on the sheet. I know you love your clients, but please don't provide clues, hints, or multiple choice answers. To score the MiniCOG, please award 1 point for each word recalled after the clock drawing. A maximum of 3 points is possible. Clock drawing is scored as all or nothing, 0 or 2 points. A 2-point clock has all of the following: all numbers 1 to 12 in correct location. Look at the anchor numbers 3, 6, 9, and 12. There will be no missing or duplicate numbers. You should see 2 hands present, one pointing to the 11 and the other to the 2. Length of the hands does not matter. Inability or refusal to draw the clock is scored 0. Normal or pass MiniCOG is a score of 4 to 5 points. Impaired or failed is 0 to 3 points. In this case, please consider referral to healthcare provider for further workup. Let's watch this short video on the MiniCOG being administered to patient Colleen.
Hi Colleen, it's nice to see you.
Thank you, it's good to be here.
It's been about 6 months, I think, since your last clinic visit.
Yes.
I understand from the nurse that you're here because of some dizziness that you've had recently.
Yes, I am.
Yeah, sounds pretty bothersome.
It is.
Well, before we look into that a little bit more, we're doing something new in the clinic, which is that just like the nurse was checking your vital signs, your pulse, your blood pressure, we're now also checking the health of the brain on a routine basis.
Okay.
And so I'm going to ask you some questions next that require a little bit of concentration. Sound okay?
Okay.
Okay. The first thing is I want you to listen carefully because I'm going to give you 3 words that I want you to repeat back to me and try to remember for later.
Okay.
You ready?
Mm-hmm.
Okay. The words are banana, sunrise, chair. Can you say those back to me?
Banana, sunrise. I don't remember the last word.
Okay. The 3 words are banana, sunrise, and chair. Can you say those back?
Banana, sunrise, and chair.
Great. Now, I'm going to give you this piece of paper with a circle on it, and what I want you to do is make a clock for me by putting in all the numbers where they go. Now, Colleen, can you set the time so it says 10 past 11? Okay, I'll take that back from you. Now, what were those 3 words that I had you repeat earlier?
Sunrise, banana, shampoo.
Okay, great, thank you. Colleen, have you had any concerns about your memory recently?
Yes,
What kind of concerns?
that I'm forgetting a lot.
Okay, what kinds of things have you been forgetting?
Things that I'm supposed to do during the day that I normally do.
Mm-hmm.
Or like when I go into a room to get something, I don't remember why I'm in there.
Mm-hmm.
And then I start cleaning and doing other things, and then I remember what I went in for, and sometimes I don't.
Mm-hmm. That's really frustrating.
Very.
Well, maybe once we're done with today's visit, it might be a good idea to have you come back so that we can look into that a little bit more. Would that be okay?
Yes, that would be fine.
Okay, sounds good.
Colleen put all the anchor numbers in the correct location, but she transposed the numbers 4 and 5 and set the hands at the 10 and the 2. That is 10 past 10, not 10 past 11. So she would receive 0 points for this clock. Colleen remembered 2 of the 3 words, so received 2 points for the word recall. She received 0 points for the clock draw, so her total score is 2 out of 5, which is a fail. Let's look at some other clocks. How would you score this clock? The score is 0 points. Visuospatial problems have affected the spacing or location of the numbers. Look at the anchor numbers 12, 6, 3, and 9. The 10 is where the 9 should be. Therefore, this is a 0-point clock. It is important to take spacing of the anchor numbers into account because this is how we incorporate evaluation of the patient's visuospatial functionings, which often deteriorate early in the course of Alzheimer's disease. How would you score this clock? Yes, the score is 0 points. Clear spacing deficits and time is represented by a single hand. This is a common response observed by patients with early dementia. How would you score this clock? Correct, 2 points. A small percentage of patients will draw the numbers on the outside of the clock. The hands are set appropriately. Note that the length of the hands does not matter when scoring the MiniCOG. And this clock? Awesome! 0 points. The time is represented by X instead of the hands of the clock. Here we have another 0-point clock. What about this one? Yes, I agree. This clock is tricky to score. First, look at the numbers. All are represented and there are no missing or duplicate numbers. The client drew 2 number 8s but recognized and self-corrected the error by scribbling out one of the 8s. This forced them to draw the number 9 a bit higher than normal. Because the client self-corrected their error, we would give them a pass. They have successfully set the time for 10 past 11. Note that the fulcrum of the hands does not need to be centered in the middle of the clock face. Therefore, this is a full-point clock. And this clock? Bingo! 2 points. The 6 is slightly out of position, but not enough to take away points. Remember, unless another number occupies the anchor position, mild spacing issues are not considered errors. Suppose you have the time and administered both the MiniCOG and the AD8. Now let's just say they passed in one and failed in another. You should encourage the client to see a healthcare provider if either the MiniCOG or the AD8 yields an abnormal score. As a CHW, your next steps would be to help facilitate an appointment with the doctor as much as the client and family will allow and/or as much as you are able to within your role. Offer to make the appointment or sit with the family while the call is made. Please try to accompany your client to the doctor if possible. Please share a copy of the screening tool, your wonderful hard work, with the doctor. Mahalo to the Administration on Community Living, to the University of Hawaii Center on Aging, and the Executive Office on Aging for sponsoring this video. Mahalo to Dr. Terry and Michelle Barkley for the slide deck and their mentorship.